Welcome to The Right Approach for Vascular Access, prepared and presented by the Mercy Medical Center IV team. The objectives of this program are to help identify and understand the use of each vascular access device, to provide education and updates of hospital policy based on current standards and guidelines, to identify complications and how to treat them, to reduce patient injury and increase patient satisfaction, and last of all, to reduce the risk of bloodstream infection related to IV access. Types of peripheral IV access, referring to an insertion in an extremity. A standard peripheral IV catheter is placed in an upper extremity, occasionally in a foot or an external jugular vein with the provider's order for difficult access patients. Typically range from a 24 to an 18 gauge catheter, and they may be short or long depending on the vessel depth and the use of ultrasound for insertion. They may dwell until clinically indicated, meaning until they are no longer needed, or there are signs and symptoms of complications. Peripheral standard catheters are used for infusion only. The second type of peripheral access is a midline, which is a catheter placed in an upper arm with the tip distal to the axilla. The catheter tip resides in peripheral circulation. There are two different types of midline catheters placed by the IV nurses. The first is a trimmable midline, which is cut to a predetermined length at the time of insertion, and the second is a power glide catheter, which is an 18 gauge catheter, 10 centimeters long. There is no consult needed, just an order for a peripheral IV access. They may be used for any peripheral infusions and blood draws. They are used for power injecting of contrast for CT scans, and they may dwell up to 29 days. Types of central access, where the catheter tip resides in central circulation. The first is a peripherally inserted central catheter, better known as a PICC, which is inserted in the upper arm with the catheter tip terminating at the cavo-atrial junction. They may be either a single or a dual lumen catheter, determined by the infusion needs. They are used for all infusions, blood draws, and power injecting of contrast. They require a PICC consult from the provider. The IV nurse therefore reviews the EMR and selects the most appropriate line determined by the needs of the patient, medications, and length of therapy. They are ideal for difficult access complex patients with incompatible vesicant and irritant medications. They are placed by the IV nurses or by the interventional radiologists. Central line catheters, or triple lumen catheters, are placed in the internal jugular, subclavian, or femoral veins. They are used for all infusions, blood draws, power injecting, and hemodynamic monitoring. Most often placed in critically ill or complex surgical patients with poor, unreliable access and multiple incompatible infusions. A Myharker dialysis catheter may have a third smaller lumen for infusion. They are placed in patients with poor access in need of acute dialysis. Only this third lumen is used for infusion. Tunneled line catheters, referred to power lines, Hickman's, and Permacath dialysis catheters. They are tunneled subcutaneously through the chest wall to the subclavian or internal jugular vein and terminate in the SVC, the superior vena cava. They may be 1, 2, or 3 lumens. They are used for all infusions, blood draws, and power injecting. They are common in patients with poor upper extremity access or renal patients to preserve extremity vasculature for future AV fistulas or grafts. A Permacath is a 2-lumen catheter for hemodialysis only. Their lumens are much larger than a triple lumen catheter. A portacath is a surgically implanted port in the arm or chest, tunneled to the IJ internal jugular, or subclavian vein with the tip terminating in the SVC. They are long-term access catheters for all infusions, blood draws, and power injecting. They are common for chemotherapy patients and patients with significant chronic conditions with poor access. Peripheral IV selection assessment. Always start distal and work your way up the arm. Avoid areas of flexion to prevent pistoning of the catheter within the vein upon joint movement. Avoid extremities affected by a mastectomy, have an AV fistula, are affected by stroke, infection, have swelling, or impaired circulation. Consider a patient's vessel size, hydration status, blood pressure when choosing the catheter size. Try using the smallest gauge catheter in the largest vessel to provide necessary infusion. Bigger is not always better. A large bore catheter may occlude blood flow and cause injury to the vessel, leading to complications, such as phlebitis. Deeper vessels may require a longer catheter to prevent infiltration. And remember, 2/3 of the catheter must be in the vessel to provide reliable access for infusion and prevent infiltration. Key points for peripheral IV insertion. Apply your tourniquet 3 to 4 inches above your intended insertion site. Apply a warm pack to dilate vessel if necessary. Clean your intended area with chlorhexidine applicator in a back and forth motion for 30 seconds, allowing 30 seconds to dry. Dry time is crucial for proper skin antisepsis. Do not retouch your site after it has been prepped. Should you need to touch it, you need to re-clean it. Apply your dressing to cover the insertion site as well as the hub connection to the tubing. Stabilize and secure the tubing above and below the site and apply an IV sleeve for increased stabilization. Label with the date, gauge size, and your initials, applying alcohol caps to all unused ports. Only 2 attempts should be made per nurse. After 2 unsuccessful nurses, please consult the IV team. Halo the IV therapy department if patient has multiple admissions or is a readmission, a history of difficult or poor access, has significant bruising, swelling, no visible or palpable vessels, and an anticipated length of stay. These 2 slides depict a properly secured IV catheter. This first slide depicts poor IV catheter placement and securement. Therefore, this catheter will not last very long. The second slide depicts improper practice with an added extension cap, increasing the risk for contamination. The most common complications related to a peripheral IV are infiltration, phlebitis, thrombus, and extravasation. All of these are reportable events and should be filed in MIDAS. Infiltration. Infiltration is the leakage of infusing fluid into the surrounding tissue at the IV insertion site. It can be caused by vessel occlusion, improper catheter placement, or catheter dislodgement, and would be evidenced by swelling, pain or tightness, coolness, and blanchable skin. The catheter should be removed, the arm elevated, and encourage range of motion if the patient is able to do so. Phlebitis is the inflammation or injury of the blood vessel caused by damage to the vessel wall during catheter insertion or infusion of irritating medication. Signs and symptoms would be redness, pain, swelling above the insertion site. It may progress to red streaking, palpable venous cord, and purulent drainage. Treatment should be catheter removal immediately and apply a warm compress. A thrombus would be a blood clot within the vessel that impedes blood flow. This could be caused by a large catheter in a small vein or a traumatic catheter insertion which has created damage to the vessel wall, creating inflammation. Signs and symptoms would be pain, redness, swelling, tenderness over the affected area. The catheter shall be removed to restore blood flow. Extravasation is the accidental infiltration of a vesicant or chemotherapeutic drug into the surrounding IV site. Signs and symptoms may be pain, burning, coolness, and swelling. This may progress to tissue sloughing, blistering, extreme pain, loss of mobility, and potentially infection. Immediately stop the infusion and attempt to aspirate. Do not flush. Remove the catheter, avoiding pressure, and elevate the extremity. Central vascular access. A central line is any vascular catheter where the tip terminates in central circulation, the SVC, IVC, or subclavian vein, regardless of the insertion site. They are used for infusion of any medications, for blood draws, hemodynamic monitoring, and power injecting of contrast medium. A PICC line is inserted in the upper arm, basilic, brachial, or cephalic vein, and terminates ideally at the cavo-atrial junction. Placement is confirmed using 3CG technology at the time of placement or chest X-ray confirmation. A copy of the 3CG confirmation will be placed in the patient's medical record and documented in the IV assessment. A triple lumen catheter is inserted either in the subclavian or IJ vein terminating in the SVC or a femoral line terminating in the IVC. A power line or Hickman is a tunneled catheter that's tunneled through the chest wall and inserted into the IJ or subclavian vein terminating in the SVC or cavo-atrial junction. A portacath or mediport are implanted in the chest wall or in the arm and tunneled into the IJ or subclavian vein and also terminating in the SVC. A permacath is a hemodialysis line inserted in the IJ, subclavian, or femoral vein, used only for dialysis treatment and is not an infusion line. However, there is a triple lumen Maharker dialysis catheter that does have 2 large lumens for hemodialysis only, with a single smaller infusion line that can be used for infusions. A peripherally inserted central catheter, more well known as a PICC, may be a single or dual lumen catheter inserted into the basilic, brachial, or cephalic vein of the upper arm with the tip terminating at the cavo-atrial junction. An order is required for a PICC consult to determine the appropriate access device. They are placed by the IV nurse at the bedside with ultrasound guidance and 3CG technology for proper placement. If it is unable to be done at the bedside, IR may require fluoroscopy for insertion. They are used for infusions, blood draws, power injecting, hemodynamic monitoring, critically ill, difficult access, and long-term infusion patients. If 3CG confirmation cannot be used, a chest X-ray will be necessary to determine proper placement prior to use. If a patient arrives with a line, it must flush easily, have a brisk blood return, and proper documentation of tip placement prior to use. If none of these are available, confirmation by chest X-ray must be done prior to the use of the line.
Triple lumen catheters are placed in critically ill or complex surgical patients that require multiple meds and require dependable access. There is no definitive duration for which a line must be removed. Each patient's condition must be considered. A daily evaluation for removal will be done by the medical team. Lines will be removed when a patient's needs can be met with less invasive IV. Power lines and tunneled lines are placed in IR to preserve the arm vasculature in renal patients that may potentially need a dialysis graft or fistula. Also in patients that have limited upper extremity access due to complications and effects from other diagnoses. These lines may dwell indefinitely if they remain free from complications. IR removes these tunneled lines when they are no longer necessary or complications develop. A portacath, also known as a mediport, are to be accessed with a provider's order by nursing staff. There is no restriction on any infusions. Placement may be for chemotherapy, long-term medication therapy, or patients with extremely bad access due to multiple hospital admissions or chronic illness. Portacath access. Verify in order to access from the physician. Identify patient and explain the procedure. Perform hand hygiene, don mask and sterile gloves. Assemble the supplies on a sterile field. Instruct the patient to turn their head away or apply a mask. Clean the site with chlorhexidine applicator, starting at the port in a back and forth motion for 30 seconds and allowing dry for 30 seconds. Assemble the Huber needle with extension tubing and the needleless connector and prime with normal saline. Leave the syringe attached. Close clamp on extension tubing. With the non-dominant hand, stabilize the port. With the dominant hand, insert the Huber needle at a 90-degree angle into the port until the needle touches the back of the port. Then remove the gripper tab. Release the clamp, aspirate for blood to confirm patency, and then flush with normal saline using push-pause technique to create a turbulent flow. Clamp your tubing and remove the syringe. Apply antimicrobial disc if there is space, TSM dressing, and secure your extension tubing. Apply your disinfecting cap. Remove gloves and perform hand hygiene. Label your dressing with the date, the length of the needle, and the initials of the inserter. Document in the ER IV assessment. Vascular access complications. All lines should flush easy with a good blood return. A midline, depending on the volume of blood in the circulation, may not always have a blood return. Catheters should be well secured to prevent complications or dislodgement. There should be no pain or swelling, and the dressing should be completely intact at all times. A phlebitis, irritation of the vessel intima from a traumatic insertion or catheter movement, you may see redness, warmth, swelling, and pain. Consider removal to relieve the irritation. A thrombus or DVT, you would note swelling and tenderness from blood clotting and impaired blood flow. Elevate the extremity, encourage range of motion. Anticoagulants may be initiated. If a PICC line remains patent and anticoagulants are not initiated, the line may not need to be removed if access is still necessary. Catheter occlusion is the inability to flush or obtain a blood return from the line caused by improper flushing technique or clamping sequence. Lines should be flushed routinely with a push-pause technique to maintain a clear line. All lines should be clamped prior to disconnecting any syringe or tubing to prevent backflow of blood into the catheter tip. A malposition, which would be a catheter tip flipping into the jugular or subclavian vein due to forceful flushing, power injecting, or a significant change in chest pressure, such as coughing or sneezing or hiccuping. Signs could be the inability to flush or obtain a blood return. Patients may complain of pain in the neck or head and hear a whooshing sound. Chest X-ray to determine catheter position and notify the IV nurse to possibly reposition back into the SVC. Please alert the IV team of any IV questions, concerns, or issues. General care and maintenance. Assess IV sites Q4 hours for signs and symptoms of complications and document in the EMR. Immediately remove any peripheral line if complications develop. Dressing changes are to be done Q7 days and PRN if compromised in any way. Prior to each line connection, the catheter hub must be scrubbed with chlorhexidine for Vantix for 30 seconds and allowed to dry for 30 seconds prior to attaching a syringe. Chlorhexidine pads are single-use only. Change caps after blood draws, at the time of dressing changes, and PRN when contaminated. Flush all lines using a push-pause technique at least daily before and after med administration and at time of disconnection. All lines should be clamped prior to disconnecting any line or syringe to prevent blood backing up in the catheter tip. Pre-filled saline flushes are single-use only. A new flush should be used every time a line is accessed. Heparin flushes will no longer be used routinely on midlines or central lines. Studies have shown proper flushing with saline is just as effective in maintaining line patency. Heparin may still be ordered if necessary. Portacasts on removal and discharge will require a single-use heparin order. IV tubing and caps. All non-additive, non-lipid-based solution tubing will be changed Q96 hours unless otherwise indicated in the EMR under the medication. All primary, continuous chemo, pressurized epidural PCA tubing will be changed Q96 hours and PRN. All blood and blood product tubing should be changed after each unit unless multiple units are administered within 4 hours. TPN and lipid infusion lines should be changed to Q24 hours. Propofol lines should be changed Q12 hours. All secondary and intermittent tubing should be changed Q24 hours. Any tubing or cap should be changed if contaminated or suspected to be. All tubing should be changed prior to connecting to a newly inserted central line or midline to prevent contamination. All disconnected lines must be capped when not in use. Do not loop back to the port or leave uncapped. All tubing should be labeled with the date, time, and initials at the time of preparation of infusion. Alcohol caps are to be applied to all unused ports and IV lines. Blood draws and blood cultures. Blood may be drawn from a peripheral line at the time of insertion only. Midlines and central lines may be used for lab draws, but not routinely for blood cultures. Blood cultures should only be drawn from a central line to rule out a catheter-related bloodstream infection or if absolutely unable to obtain blood otherwise. A provider's order should specifically state line draw. A midline or power glide may require a tourniquet to be placed high in the axilla above the catheter tip and recommend drawing with a syringe versus the use of a transfer device. A vacutainer may create too much pressure and collapse the vessel. Blood draws from a central line. Perform hand hygiene and don gloves. Remove the needleless connector from the clamped line. Scrub the hub with chlorhexidine wipe per Vantix for 30 seconds and allow to dry 30 seconds. Attach the saline flush syringe. Release the cap and assess for a blood return. Flush with 3 to 10 mL normal saline using a push-pause technique. Pull back an equal amount of blood for discard. Reclamp the catheter and discard the blood in an appropriate container. Scrub the hub again for 30 seconds, allowing to dry completely. Attach the vacutainer. Release the clamp and insert lab tubes. Clamp the line, remove the vacutainer, Scrub the hub for 30 seconds, allowing to dry again for 30 seconds. Attach a new saline primed connector. Unclamp and flush using push-pause technique. Reclamp and attach orange disinfectant cap. Catheter removals. Short-term peripheral catheters may be removed by any RN if complications develop and are no longer needed. Peripheral catheters are replaced when clinically necessary and do not need to be routinely changed. Midline catheters are removed by competent trained nurses when no longer necessary. Catheter length verified at the time of removal. No order is necessary. Consult the IV team if any complications are noted prior to removal. Dwell time may be up to 29 days. PICC lines are removed by competent trained nurses when no longer necessary. Catheter length is verified at time of removal, and petroleum occlusive dressing is applied. IV team should be notified of issues or complications prior to removal. There is no predetermined dwell time for a PICC if there is no complications. Triple lumen catheters are removed by competent trained nurses when no longer necessary. There is no predetermined dwell time. Catheter removal will be assessed daily and removed when patient's condition can be treated with a less invasive access device. A power line is considered a long-term access line with no predetermined dwell time and is removed in IR when no longer necessary due to being tunneled and cuffed. A portacath is a surgically implanted catheter for long-term access, not usually removed unless it is malfunctioning or there is a concern for infection. Removed in the IR or OR only. The IV team can be reached by halo messaging the IV therapy, generally between the hours of 7 A and 7 P, 7 days a week. When to call the IV team. When you have patients that are difficult to access, have multiple bruises and infiltrates, and require multiple restarts due to poor vasculature, the inability to flush a line, or the line is sluggish or hard to flush, the inability to draw blood from a central line or midline, if a mid or a central line dressing is soiled, peeling, or leaking, when the patient complains of pain and swelling in an arm with a mid or a central line, any issues or complications related to vascular access lines, the discontinuation of a midline PICC or triple lumen line, and please, if you have any questions or concerns regarding a patient's vascular access, please contact the IV team by halo messaging IV therapy or the beeper 3372, or our office number is 67428. Thank you, and I hope you find this helpful.